చూడు ఇప్పుడు చూడు
అప్కమింగ్ అని వస్తుంది.
వస్తుంది కదా. ఏం అదే వస్తుంది. వస్తుంది కదా. Okay. If possible, ask them to join others also. If you are okay, just message me, Nidhi. Waiting for the students to join. Just waiting for everybody to join. It's wonderful to see you all. Okay, joining. Okay, waiting for the students to join. Waiting for everybody to join. It's wonderful to connect with you. Okay, everybody is joining. Waiting for everybody to join. Okay, we start without wasting your time. Hi, so good evening to see you all. Today we are going to start discussion about the how to prepare for that is a PCT, part completion test, and not only for part completion test, it is also useful for your university examination. First, you must know what is the exam pattern. That is the first you have exam for 180 marks. Out of 100 marks or 80 marks is that is a written exam. That is a short answers and essay questions, and 20 marks MCQs. Right, among descriptive, that is first one question is for the 10 marks, that is essay question, and remaining 11 short answers for 5 marks each, and remaining all are 10 short answers, very short answers, that is for the 3 marks. So that is the pattern of question paper pattern. And the next sorry, not 10 marks, 5 questions for each 3 marks, that is for 15 marks. 3 marks questions are 5 and each carries 3 marks, and the total 15 marks, and 5 marks questions are 11, each question carries 5 marks, and total 55 marks, and 10 marks for essay question, right? And among these all descriptive questions, again it may be different types. So that is reasoning questions. Last year onwards they started reasoning questions, clinical questions, and direct short answers. Among the reasoning questions, that is mostly they are clinical oriented, that is diagnosis oriented or some clinical orientation, and clinical questions are also clinical orientation. That is because now CBME started clinical oriented training from the first phase 1 MBBS onwards. That is why in examination pattern also like that, right? To prepare for this one, first you start with I think all of you know about the general anatomy, general terminology, planes, everything. I think there is no need to explain. And usually we study anatomy in different categories. That is like gross anatomy, microscopic anatomy, next systemic anatomy, radiological anatomy, like that. We use different genetics related anatomy, experimental anatomy, applied anatomy. Okay, these are all the physical anthropology, comparative anatomy. Okay, like this there are different types of anatomies we are going to study. Next, if you see the general anatomy, whatever the book you are following, that is it may be B.D. Chaurasya handbook of general anatomy is there, or that is another one is Vishram Singh general anatomy is also available. Whatever the textbook you are following, you just see. First one is classification of bones. That is very important question for your examination purpose. Classification of bones and classification of joints. That is first one is classification of bones. That is long bones, short bones, irregular bones, flat bones, sesamoid bones. Okay, these are all the classification of bones you are supposed to know. Next, coming to the another important topic, that is the blood supply to the bones. That is also very important in our examination purpose. That is blood supply to the long bones especially. That is in that you are supposed to know about the different arteries which are supplying to the long bones. That is nutrient artery, metaphyseal artery, okay, periosteal arteries, epiphyseal arteries. That is very important. The branches from the different regional arteries they are supplying to the bones. Especially this you must practice the diagram that is given in the general anatomy textbook. That is blood supply to the long bones. Okay, that is a very important diagram. All of you must practice. Okay, that is number 1. And next, that is metaphyseal arteries are very important, especially while growing bones. in the children's, especially it is important in children's. That is because these arteries are formed like a hairpin bends, and these hairpin bends are more prone for that is obstruction. Okay, this obstruction may lead to that is bone deformities. That is the metaphyseal branches. They may blocked, and it may lead to there is a development abnormalities. Okay, that is one important clinical point you are supposed to know. And the next is joints classification of the joints. That is also very important. Classification of the joints. Among the classification of joints, there is a fibrous joints. That is very important because these are the joints which are present between the skull bones. And again, the fibrous joints, there are different types. That is different synarthrosis, syndesmosis, amphiarthrosis, like that. And all these classification also is supposed to study along with the diagrams. Okay, in anatomy, whatever the topic you are studying in anatomy, you must draw neat label diagram if you want to get good marks. Otherwise, they may give marks, but it is less marks. Okay, that is very important. Diagram with the matter, it gives more marks. And next, coming to the synovial joints. So synovial joints is also very important. Okay, that is the synovial joints. Again, the classification of the synovial joints, especially plain synovial joints, ball and socket variety of synovial joint, pivot variety, condylar variety, ellipsoid variety, and all these types of joints plus examples you are supposed to remember. Okay, practice. If possible, try to draw relevant diagrams also. Okay, that is another important topic related to the general anatomy. That is the classification of joints. And next, coming to the another important topic related to general anatomy, that is the muscles and all these things we cover in the gross anatomy. That is why you don't worry about the muscles in the general anatomy. Okay, and CVS, these all systems will cover. Only thing is here is supposed to remember, that is anastomosis. That is one important point. Sinusoids and anastomosis between the blood vessels. That is anastomosis between the arterial anastomosis, arteriovenous anastomosis, like that there are different types. Okay, all these anastomosis are very important clinically because these playing most important role in blood supply to the especially vital organs like brain and heart. If there is any blockage because of this anastomosis, there is a bypassing of blood. Suppose if you see, that is if the young people gets a heart attack, they are very commonly they die because in young people there is no proper anastomosis between the end arteries of the arteries which are supplying to the heart. That is the coronary arteries. That is why this anastomosis and so another important thing, there is one procedure we perform in renal failure patients, especially if the patient underwent hemodialysis. In those individuals, we need to increase the blood flow through the veins in the particular area. That is why they perform a procedure that is called arteriovenous anastomosis, and that is the very important and essential procedure to maintain blood flow during dialysis process. Okay, that is why that is also very important. Okay, like that you are supposed to study about the anastomosis of the blood vessels. And next, coming to the these lymphatic systems, everything we will discuss in gross anatomy, and structure of the lymph nodes, everything we will discuss. And next, what is there in the general anatomy? Okay, these are all the things we are already just for the knowledge purpose you can study all these things. Otherwise, we will skip all these things. Just these are not much important for the examination purpose, right? Next, coming to the lower limb. Okay, lower limb, whatever the book you are following, suppose if you take first chapter of the lower limb, that is introduction. After introduction, you will get to osteology. In osteology, first bone is the this one. This is the pelvic bone. Okay, this is the what is this bone? Hip bone, right? Just comment. And this is the hip bone, or this is also called innominate bone. Okay, this is the bone of the pelvic girdle. Pelvic girdle. Okay, and first whatever the bone given to you at the time of examination, most of the occasions these bones they are asked in the practical exam only, or viva, especially viva they may ask osteology related questions. Some bones are important clinically. Okay, that is why they may ask in the theory examination also, but mostly they ask in the practical examination. Whatever bone you take during viva, you're supposed to keep the bone. First you have to identify the bone, that is this is the hip bone or nominate bone. Then you have to say either it is a right side or left side, because there are two hip bones. Okay, that is it is a right side or left side you're supposed to say. Next, afterwards, how can you say it is a right side or left side? That is important. Okay. First, you have to keep the bone in anatomical position. That is the very important point. Okay, especially for this, what is this one? This is the hip bone. How to keep hip bone in anatomical position? There are three most important points you must keep in mind while keeping the hip bone in anatomical position. The first one is upper. This is the expanded portion is upper one, and lower extended portion. In between these two there is a narrow area, and in this narrow area in the posteriorly there is a big groove, and this is called greater sciatic notch. It must be posterior, that is number one. Number two is here you can see, you can find out that this is the acetabular foramen, big fossa. Here there is a big fossa, this is called acetabular fossa. It must be lateral. That is another important point. And just below this acetabular fossa, here there is one big foramen. This is called obturator foramen. Obturator foramen must be below. Okay, these are the 3 points. First one is upper expanded portion above and lower expanded portion below. And this greater sciatic notch must be posterior, and ischial, that is a acetabular fossa, must be lateral, and acetabular obturator foramen must be inferior. Okay, this is in this way you can say. And another important thing, while holding this bone in anatomical position, you must hold this one is called anterior superior iliac spine, and here you will get another bony prominence. This is the pubic tubercle, and these two must be in the same coronal plane. Coronal plane means that is the plane, it divides our body into anterior and posterior halves. Okay, so that is why this is the coronal plane, and you have to keep this bone in the same, these two structures must come into same coronal plane. Then that is the okay, whatever the side it belongs to, we have to hold the bone with that hand like this. Okay, that is the point you are supposed to remember. Like this you have to hold the bone in anatomical position. Okay, that is the one important aspect related to this hip bone, right? And next in future classes we will discuss individually in detail about the individual bones. Okay, next we take up another bone, that is the femur. Okay, this is the femur. Okay, this is also called thigh bone, and this is the longest bone in our body, and it is the length of the femur is 45 centimeters, or it is a 1/4 of the total height of the individual, 1/4 of the length of the total height of the individual, that is the femur. Okay, it is also called thigh bone. Okay, next here how to keep femur in anatomical position. This is also very important and most commonly asked question. Here you should not hold femur like this straight, because in our body the femur itself is oriented like obliquely like this. Okay, it is not straight like this, it is not straight, it is oblique. It is obliquely oriented because these two condyles must be come in contact with the tibial condyles. You can see this is the tibia and it must be fitted like this. Okay, otherwise it is very difficult to walk. Okay, so that is why this, you see the angle between this one, naturally the femur is oriented obliquely. Okay, that is why you have to keep the femur obliquely. Then you put your finger like this. Okay, below the neck and the junction of the neck and head of the femur. Then you hold like this. Okay, this is the right position to hold. And another important, head must be directed forwards, upwards, and medially. Forwards, upwards, and medially. And this part is called shaft. That is, the shaft must be convex anteriorly. Shaft must be convex anteriorly, and this is the lower expanded end. This is the lower end, and it is here there is a posteriorly there is a one groove, one ridge, that is called linea aspera. Linea aspera must be posterior. Okay, so that is the how to hold femur in anatomical position. Okay, this is also called thigh bone. Thigh because is the present in the thigh. Okay, that is the one important point you remember about this femur, right? And next, coming to the another bone, this is the tibia. This is also leg bone. Okay, in the leg we are having two bones. We have two bones in the leg. That is, one is the medial and the strong bone is the tibia, and lateral and small bone is the fibula, right? These two bones they are playing most important role in one is this is, suppose if you take tibia, it is providing strength or transmission of the weight transmission. Okay, and this one, it is a most important bone to provide muscle attachment, surface for the muscle attachment. Okay, that is why each bone it is having its own important. One is not important, another one is not, like that. Okay, each bone is having its own importance, especially the tibia. Okay, how to hold tibia in anatomical position? That is, the upper part is called expanded part, upper end, and lower part is lower end, and this is the shaft. And here the sharp border is there. Here, if you observe the tibia, here there is a sharp border, and this sharp border is called anterior border. It must be front or forward. Okay. Next, this here there is a one bony expansion from the lower end, and this is called medial malleolus. Medial malleolus. This medial malleolus must be medial side. Medial malleolus must be medial side, and upper end is expanded end. Okay, so then if you hold like this, then here you will get the lateral side, you will get articular facet. This articulates with the corresponding fibula. Okay, so that help of this one, you can determine the side of the tibia, right? And next, coming to the another bone, this is the fibula. This is another leg bone, right? Here it is having the upper end, lower end, and shaft, right? Upper end is expanded, and here you will see a small expansion from the upper end. This is called a styloid process. The styloid process must be posterolateral. Styloid process must be posterolateral. And next, in the lower end, you will get a small depression. Okay, this is called malleolar fossa. Malleolar fossa. Malleolar fossa must be posterior-inferior. Posterior-inferior. So, if you hold like this, and this is the anatomical position, then this belongs to left side. Okay, left side, you see here, this is the styloid process is posterolateral, and malleolar fossa is also posterior-inferior to the, here there is a one triangular articular facet. Okay, it articulates with the talus. Okay, lateral end of the lateral surface of the talus. Okay, and here upper end also having another articular surface. This is the triangular articular surface, oval articular surface. It articulates with the lateral condyle of the tibia. Okay, right? So that is the, and here in fibula it is having three borders, that is anterior border, interosseous or medial border, and posterior border, and it is having three surfaces, that is medial surface, lateral surface, and posterior surface. So here while determining the side of the fibula, 2 points are very important. First one is this malleolar fossa. Malleolar fossa must be yes, you can share. Neither you can share in a group. Okay, anybody can join. Right? Thank you. Okay, here you see this is the malleolar fossa. It must be posterior-inferior, and we have to keep corresponding the thumb, tip of the thumb in that malleolar fossa, then you have to hold like this. Okay, this is the holding correct anatomical position of the fibula. Okay, that is the another important point you must remember. Okay, so these are all the three bones, large bones which are present in big bones in the lower limb. Okay, remaining bones, so that is the tarsal bones, metatarsals and phalanges, we discuss later. Okay, and next coming to the gross anatomy after osteology. Okay, the first and foremost important thing here is, and here an important point you must remember, and that is venous drainage and lymphatic drainage of the lower limb. It is clinically, it is very important, because many patients they are, hi, good evening. Okay, good evening all, thank you for joining. Okay, this lower, especially venous drainage of the lower limb, it is very important. That is a big clinically, because many patients, especially in our population, that almost 30% of the people, they are suffering with venous problems. Okay, that is because of the failure of the veins or failure of the that is valves, or because of the profession. That is, suppose if you see people who are used to stand for a prolonged time, they may suffer from this venous problems, especially related to the lower limbs, because these from the lower limbs the blood must move against the gravity. Okay, that is it must be facilitated by muscle contractions and the pulsations of the arteries, and the valves, they are inbuilt, they are present within the veins. So there are many valves. These valves, they are preventing backflow. Okay, in that way, and muscle contractions and the pulsations of the arteries, they are accompanying the vena comitatus, and they are facilitating the pumping of blood towards the heart. Okay, that is why this venous drainage, it is clinically, it is very important. Many people, they are nowadays, many people, they are suffering with varicose veins. What is varicose veins? That is a abnormal dilatation of the veins of the lower limb, whatever it may be there, not only lower limb. Okay, we are concerned with the lower limb, that is why I am telling. Okay, otherwise varicose seal, that is also present in the scrotum or anywhere in the body, there may be chances for dilatation of the veins. But here, the lower limbs, we are having good evening all. Okay, in lower limbs we have two major veins. One is that is the great saphenous vein, another one is the short saphenous vein. Out of this, the great saphenous vein is the very important vein, and it is the longest vein in the body. This is the longest cutaneous vein or subcutaneous vein, superficial vein in the body. And here in the lower limb, the venous system, it is having three veins. That is, first one is superficial veins, next is the deep veins, and in between the superficial veins and deep veins, there are connecting veins, there are perforating veins. And if you want to maintain perfect venous return from the lower part of the body to the heart, all these veins and its walls must act properly. Otherwise, the individual develops problems, clinical problems related to veins. Okay, so that is why this venous drainage of the lower limb, for our examination purpose, it is very important. And one basic thing is supposed to remember, if there are if nerves divide into branches, arteries divide into branches, but veins, they form by joining the tributaries. Okay, that is, don't use a term in the while describing about the veins, so don't use the term branches. Okay, you must write tributaries of the veins, because they are joining together, they are forming the bigger veins. So finally, all the veins of the lower part of the body below the heart, all together they form the inferior vena cava. Okay, that is most of the vessels, veins, there are the branches of the tributaries of the inferior vena cava. Okay, so that is why you use term tributaries in the veins, branches in the arteries, and branches in the nerves. Okay, that is the one basic thing while writing examination also. Many because of my experience, many students they used to write branches of the veins like that, except there are some special veins, that is portal veins, they divide into two divisions. Okay, right and left hepatic veins. Otherwise remaining all are tributaries only, right? That is one important point. So you first if you want to write about the great saphenous vein, first you have to write formation of the great saphenous vein, where it forms the dorsum of the foot. Dorsum of the foot. It is formed by joining of all the proper distal veins. Then they join together, they form the common distal veins, and all these common distal veins they join with an arch-like structure over the dorsum of the foot. Then this arch of the foot, venous arch over the dorsum of the foot, that is called dorsal venous arch. This dorsal venous arch, it is having two ends. One is the medial end and the other is the lateral end. The medial end continues upwards as the in front of the medial malleolus. That is also very important landmark. Just in front, 1 inch in front of the medial malleolus, the great saphenous vein forms. That is nothing but the continuation of the upward continuation of the medial end of the dorsal venous arch. Okay, then it runs upwards the medial side of the leg, then posterior to the knee joint, then medial side of the thigh, then finally it joins with, and meanwhile while its journey it receives many tributaries from the different parts of the lower limb, especially that is a superficial tributaries. Then finally it joins with the femoral vein by piercing that is a cribriform fascia at the saphenous opening. Saphenous opening, what is saphenous opening? It is a oval opening that is present in the deep fascia of the thigh. That is in the fascia lata. In the fascia lata of the thigh, especially in the below and lateral to the pubic tubercle, there is a opening that is called saphenous opening, and this saphenous opening, it is covered by a fascia that is called cribriform fascia. Cribriform fascia. Then this great saphenous vein. Here one important thing you remember, the branches of the femoral artery, they pierce the cribriform fascia from deep to superficial, then they comes out superficially, then it supplies to the superficial structures of the thigh. But the tributaries of the great saphenous vein, they are joining with the great saphenous vein. The great saphenous vein piercing the cribriform fascia, not the tributaries, right? That is one important point you remember, right? That is, sometimes they may ask in the exam also. Okay, that is why that is the important point you remember. Then finally it drains with the femoral vein. The great saphenous vein drains with the femoral vein, then there ends. Okay, then here there is a one important valve is there, big valve, clinically very important valve, that is called saphenofemoral valve. Saphenofemoral. Unfortunately, in 20 to 30% of the individuals, this saphenofemoral valve is incompetent. What is the function of the valves? That is they maintain unidirectional flow of blood. Okay, that is they prevent backflow. But in these individuals, what they do, they are unable to work properly, then the individual may prone for varicose veins. Okay, that is the thing. And not only the saphenofemoral valve, in between also from medial malleolus up to the saphenous opening, in between also there are many valves at the knee, just at the level of the knee joint and the middle of the thigh, middle of the leg, and there are many valves. Okay, all these valves, they are helpful for the backward flow of blood. Okay, so that is why this venous drainage of the lower limb clinically it is very, very important. Okay, one thing you must remember. Next, another one, that is the thigh region. Again, another important thing, that is the femoral triangle. This femoral triangle is also clinically very important, and in your examination purpose also this clinical femoral triangle is very, very important. Okay, good evening all. Okay, next this femoral triangle. It is a triangular area in front of the thigh, especially upper 1/3 of the thigh. Okay, that is another important point. Upper 1/3 of the thigh, for our convenience, we are dividing into 3 parts. That is upper 1/3, middle 1/3. Femoral thigh is divided into 3 parts. That is upper 1/3, middle 1/3, lower 1/3. And upper 1/3 it is occupied by femoral triangle. In the middle 1/3 there is another canal that is called adductor canal, or we also called, there is a subsartorial canal and Hunter's canal, and lower 1/3 it is by the popliteal artery. Okay, so this thigh upper 1/3 it is formed by femoral triangle. This femoral triangle also clinically very important, because while if you want to perform any procedure, and especially for the dialysis, initial first stage of dialysis, and any some procedures, that is just like cardiac catheterization, we used to pass catheters through the femoral vein. Okay, the femoral vein and femoral artery and femoral nerve and femoral canal, these are all the contents of the femoral triangle. Okay, that is why this femoral triangle is also very important. All of you must practice the diagrams related to femoral triangle. Okay, that is the boundaries of the femoral triangle. There is a medial boundary, lateral boundary, base, apex, floor, roof. What are the structures all forming the boundaries to the femoral triangle? Okay, that is another important. Next, contents of the femoral triangle. Okay, that is also very important, right? Next, coming to the another important thing, adductor canal. Adductor canal is also very important in your examination purpose. That is, you have to study about adductor canal. That is the boundaries and contents, and it's a clinical anatomy. Why it is called Hunter's canal? Okay, like that you have to practice. Okay, that is another important thing. And most important thing in anatomy you have to remember is you must practice diagrams. Okay, diagrams are very, very essential in anatomy. Next, knee joint. Knee joint is also very important essay question in an examination point of view. Not only essay question, it is also helpful for the short answer. Sometimes they may ask that is synovial sheaths or bursa around the knee joint, or sometimes they may ask the intra-articular structures of the knee joint, or sometimes they may ask ligaments of the knee joint. Okay, hi everybody. Okay, ligaments of the knee joint, like that they may ask short answers. Okay, that is why don't neglect the knee joint, right? And another thing, in the medial compartment of the thigh, there is an important nerve that is called obturator nerve, and sometimes there may be abnormal obturator artery. Abnormal obturator artery, it is a branch from the external iliac artery usually, but sometimes the inferior epigastric artery may send some big branch. Normally it is very small, but in some individuals it may be big. Then if you accidentally, if you cut this one, they may enter into dangerous clinical conditions, that is blood loss, and sometimes they may die also. Okay, that is why that is also very important. Okay, that is the thing. Next, coming to the gluteal region, especially in the gluteal region, that is Trendelenburg's sign. There is one important clinical point related to Trendelenburg cell. That is if you cause, while giving intramuscular injections in the gluteal region, if you cause any damage to the, especially to the superior gluteal nerve. Okay, this gluteal region, it is supplied by two nerves. One is the superior gluteal nerve, another one is the inferior gluteal nerve, right? And if you, while giving intramuscular injection to the gluteal region, this anatomy concept behind intramuscular injection to the gluteal region, that is also an important question. And Trendelenburg sign is also very important question. What is this one? This superior gluteal nerve, it supplies to the that is gluteal region muscles. That is gluteus medius, gluteus minimus, and tensor fasciae. These three muscles, they are supplied by the superior gluteal nerve. Okay, while suppose if you give misplace the needle while giving intramuscular injection in the gluteal region, it may cause direct injury to this superior gluteal nerve, and it may lead to paralysis of these three muscles. Then it is unable to maintain the balance. Okay, that is these three muscles are playing most important role while balancing the pelvis while walking. Okay, suppose if this gets paralyzed, the pelvis may sink to one side. Okay, that is why this is also called this area. This sign is called Trendelenburg sign. Okay, this also you are supposed to read. So that is also very important question in your examination point of view. And next, sciatic nerve. Sciatic nerve is also important. Sciatic nerve, tibial nerve, and common peroneal nerve and its branches. As there is a deep and superficial peroneal nerve. Okay. Next, popliteal fossa. Popliteal fossa is also very important question in your examination point of view. Here you are supposed to study. First, you have to draw diagram. Then you study boundaries and contents of the femoral, there is popliteal fossa, and clinical aspect related to the popliteal fossa. That is Baker's cyst, and next popliteal aneurysm. Popliteal aneurysm. Okay, that is also very important question in your examination point of view. And next thing is there is a Coming to the leg. Okay, next leg, in the leg, that is compartments, especially the superficial peroneal nerve, or this is also called musculocutaneous nerve of the leg. Musculocutaneous nerve of the leg. Okay, that is also why it is called musculocutaneous nerve. First it supplies to the muscles, then it supplies to the skin. That is why it is called musculocutaneous nerve. Right? This is the branch from the common peroneal nerve. And another one is the deep peroneal nerve. It is the nerve of the anterior compartment. That also you have to study. And next, in the posterior compartment, especially the peroneal compartment, that is the lateral compartment. The nerve of the lateral compartment is the superficial peroneal nerve or musculocutaneous nerve. And the muscles of the peroneal compartment are long and short peroneus muscle. There is a peroneus longus and peroneus brevis muscles. Okay, these are the muscles and nerve of the peroneal compartment is the superficial peroneal nerve. Okay, that is also very important. And next, coming to the another important point in the thigh is I forgot, that is anastomosis between the arteries. Okay, that is also important because in the posterior compartment of the thigh there is no big vessel. Okay, only thing is that is the branches from the femoral artery, especially the profunda femoris artery. This is also very important question. Profunda femoris artery, and the branches from the profunda femoris artery, they pierce the that is adductor magnus muscle, then they go back and they form arterial anastomosis. That is there are different anastomosis, that is cruciate anastomosis, the trochanteric anastomosis, and next is the anastomosis around the knee joint. Okay, these are the anastomosis also very important. Along you must practice along with the diagrams these anastomosis. Okay, that is another important question you're supposed to learn. In the thigh. Next, coming to in the leg, posterior compartment of the leg. Posterior compartment of the leg, that is also called calf muscles. They are called calf muscles, and especially here there are the muscles. That is superficial most muscle is the gastrocnemius. Then deep to that there is a soleus, and above there is a popliteus, and then flexor hallucis longus, flexor digitorum longus, and deepermost muscle is the tibialis posterior. Out of this, the soleus muscle is having a special unique feature because this within the soleus muscle there is a flexus that is called soleal flexus of veins. Okay, these soleal flexus of veins they are pumping blood against the gravity. That is why they are called peripheral hearts. Okay, they are acting like a peripheral heart, secondary heart in our body. That is the peripheral heart. In an examination, most of the occasions they ask what is the concept behind peripheral heart or anatomical basis of peripheral heart. Within the soleus muscle there are venous sinuses, and these venous sinuses, within the venous sinuses there is a pooling of blood. Whenever there is a contraction of this muscle, this blood is pumped against the gravity towards the heart because of with the help of the valves. Okay, that is why this is called a peripheral heart. And next is this another important clinical point related to this peripheral or soleus muscle is because of pooling of blood in the soleal plexus of veins, especially venous sinuses, especially in paralyzed patients or bedridden patients, because of lack of exercise, this blood may be stagnated and it may be form clots. Okay, these clots, thrombus or formation of clots, that is called thrombus. And this thrombus may dislodge from the site of formation, then it may enter into the blood circulation, that is called thromboembolism. And this thromboembolism may go somewhere in the body, especially it may block the blood vessels of the brain, it may block the blood vessels of the heart, or it may block the blood vessels of the lung. Then it leads to its own complications. Okay, that is why that is called formation of clots in the deep veins, they are called DVT. Deep vein thrombosis. That is the most dangerous complication which is related to the venous plexus in the soleus muscle. Okay, that is also very important. One soleus related 2 points are very important. One is DVT. In the DVT, what happens is that the patient complains severe pain, swelling, that is inflammation of the veins, and highly painful. Okay, that is the explanation. And they may give clinical oriented questions. So the patient is a bedridden patient complaining of swelling and pain in the calf region. Okay, what is the diagnosis? Like that they may ask. Okay, that is why you must No. Okay. That is another important clinical question they may ask. Next is now coming to the foot. In the foot, and another important point related to this leg is compartmental syndrome. Compartmental syndrome is also very important clinical question. That is whatever the say suppose if there is any injury to this or crush injuries to the bones or muscles in the leg, it may cause inflammatory reaction, it may produce swelling, and this swelling may compress over the blood vessels and nerves which are passing through the compartments. Then the individual develops compartmental syndrome. Okay, that is why this is also very important. To relieve this one, we have to cut the skin superficial fascia and deep fascia. That is to relieve the pressure in the compartments. And after some time again, after giving some treatment like antibiotics, painkillers, or anti-inflammatory drugs and elevation, over a period of time, within 1 week or 10 days, everything will subside. Then we stitch. Okay, that is it make the normal. Okay, that is also another important point that is related to the compartmental syndrome. Next thing is that is another important artery which is related to the leg anterior compartment, the anterior tibial artery. It continues down as the dorsalis pedis artery. Dorsalis pedis artery. This is also very important question in your examination point of view. Dorsalis pedis artery. Okay, dorsalis pedis artery pulsations. Feeling the dorsalis pedis artery pulsations are very important in especially in fractures of the lower limb, especially femur fracture. In femur fracture, what happens? In the femur, it is very closely related to the femoral artery. Okay, if there is a fracture of the femur, these fragments of the fracture they may be irregular and they may pierce the femoral artery, and it may cause formation of big clot in the thigh. Then there is no blood supply to the distal part of this fracture. Then it leads to lack of blood supply to the lower part. Then the patient may develop avascular necrosis and gangrene in the lower part of the leg. Okay. Or sometimes because of compartmental syndrome, there may be compression over this anterior tibial artery. Then it leads to absence of pulsations in the dorsalis pedis artery. Okay, that is why this dorsalis pedis artery is very important for the orthopedic surgeons. Orthopedic surgeons usually if you see any patients who receives this fracture on the leg or thigh bones, first you have to feel the dorsalis pedis artery pulsations to check whether there are pulsations are there. If the pulsations are there, we are happy. Okay, otherwise you have to investigate where it gets obstructed. Okay, blood flow gets obstructed and it is a surgical emergency. Okay, that is why the dorsalis pedis artery also very important. Another important question related to lower limb. Next, coming to the related to the foot, that is if you go plantar aspect of the foot, there are layers. That is first layer, second layer, third layer, fourth layer. There are layers in the plantar aspect of the foot. In these layers, especially the second layer, it consists of important structures. That is why in examination they may ask, draw the neat label diagram of the second layer of the foot and explain the contents. Okay, that is another important question you may get in your examination. That is one thing. Next, another important thing related to the foot, that is arches of the foot. Arches of the foot. That is there are the foot already foot is like this, not like this flat. Okay, so there are arches. That is in the arches again there are longitudinal arches, again longitudinal and medial longitudinal, lateral longitudinal arches, and transverse arches. Okay, transverse, and all these arches are maintained with the help of the bones, ligaments, tendons, and muscles. Okay, all these structures they are playing most important role in maintaining any arch, whether it be a longitudinal arch or transverse arch or medial longitudinal or lateral longitudinal. All these arches are maintained with the help of the muscles, tendons, ligaments, and bones. Okay, so these are all the playing most important role. Okay. That is why this is also most commonly asked question in final exam or in PCT, part completion test, or in internal assessment also related with the foot. Most of the occasions they ask dorsalis pedis artery, second layer of the sole, and there is arches of the foot. Okay, arches of the foot may be asked for the essay question, 10 marks, or there is a medial longitudinal arch, or about the lateral longitudinal arch, or transverse arches. Individually they may ask as a shortens. Okay, that is also another important question, right? And next, coming to the thigh again, there is one important clinical point you must remember, that is obturator nerve. Obturator nerve, it is coming from the lumbar plexus, right? That is L2, L3, L4 nerves. Okay, then it passes through the posterior abdominal wall within the this psoas major muscle. Psoas major muscle, already I think we discussed. Psoas major muscle, that is the posterior abdominal wall muscle. Okay, then it starts from the lumbar region, then it enters into the thigh, then it gets inserted to the lesser trochanter of the femur, right? While passing through this, it is covered by a fascia that is called psoas fascia. Psoas fascia. And sometimes in patients who are having less immunity, especially people who are suffering with tuberculosis, HIV infections, or patient who receives cancer treatment, cancer treatments, okay, in those individuals, usually naturally the immune levels are less, and people who are suffering with uncontrolled diabetes mellitus, in those individuals, there is a formation of pus in the psoas muscle. That is why it is called psoas abscess. Okay, what is abscess? Anywhere in the body, if there is a collection of localized collection of pus, is called abscess. If the pus is formed within the psoas muscle, that is called psoas abscess. Okay, that is also one important. Here, this if there is a formation of psoas abscess, what happens? This obturator now it passing through the psoas major muscle, and this obturator now it is having wide distribution. That is, it is applying to the joints, that is especially the hip joint and knee joint, and it is applying to the muscles, that is articular fibers, articular branches, and it is also supplying to the muscles of the medial compartment of the thigh. They are called muscular branches, and it is also having vascular branches, and it supplies to the blood vessels in the medial side of the thigh, and it is also having cutaneous branches. It supplies to the medial side of the thigh, especially adductor compartment or the adductor compartment. Okay, that is why this obturator nerve is also clinically very important. And here another important point, especially in females, there is one important clinical point you must know, that is while passing its journey from the lumbar region, then it enters into the crossing the pelvic brim, then it enters into the pelvis. Within the pelvis, it passes through the lateral pelvic wall. While passing through the lateral pelvic wall, okay, it is related to the fossa for ovary. Okay, where ovarian fossa. Ovarian passes through the floor of the ovarian fossa. Okay, that is why whenever there is a irritation or inflammation of the ovary, that is called ovareitis, it causes irritation to the nerve also. Then the patient complaining of pain in the middle side of the thigh, or pain in the knee joint, or pain in the hip joint also. Okay, if without any inflammatory local manifestations, without any pathology related to the knee joint or a middle side of the thigh or hip joint, if the patient is complaining of chronic pain, pathology. That is one of the important clinical point you must remember, especially in females, right? And sometimes there is one clinical condition that is called inflammation or infection to the vertebral column, that is especially tuberculous infections, that is called Pott's disease. In Pott's disease, what happens? There is a collection of pus in the vertebral bodies, because the tuberculous bacillus, it erodes there is a bone, and it forms cavities. They are filled with the pus, and this pus may goes down along with the course of this obturator nerve. Then it may reach this pus, along with the pus, the bacteria may reach the hip joint. Then it may produce tubercular arthritis of the knee joint or tubercular arthritis of the hip joint also. Okay, so that is why all these things you are supposed to keep in mind in applied anatomy related to the obturator nerve. Okay, that is why the obturator nerve, it is the most commonly asked question in our examination related to the adductor canal, especially to the lower limb. And next, in the adductor compartment, there is one important muscle, that is adductor brevis. Adductor brevis is called key muscle in the adductor compartment. Okay, that is because this is the muscle superficial to this muscle, that is superficial division of the obturator nerve passes, and deep to this muscle, the deep division or posterior division of the obturator nerve passes. Okay, that is why while performing any surgeries related to the adductor compartment or middle compartment of the thigh, you must take into consideration that is the position of the branches of the obturator nerve. That is why obturator nerve is also most frequently asked question in our examination. Okay, that is a obturator nerve, and it is there are some defacial modifications. Defacial modifications in the lower limb, especially in the upper part of the thigh, especially in the thigh, in the lateral side, there is a one thickened band of defascia that is called iliotibial tract. Why it is called iliotibial tract? Because it extends from the ilium, okay, ilium of the hip bone, especially this is the iliac tubercle. Okay, from the iliac tubercle to the tibia. Okay, that is why tibia, especially the lateral condyle of the tibia, lateral condyle of the tibia. That is why it is called iliotibial tract. Okay, this iliotibial tract is a thickened band of defascia in the lateral aspect of the thigh. Okay, and here this attached to this one only, there is a one muscle that is called tensor fascia lata. Tensor fascia lata in the posterior compartment of the thigh. That is a muscle. Tenses the this defascia, especially the fascia lata. This fascia lata is very important to maintain the erect standing posture. And it is also clinically used for that is if there is a suppose in our body, suppose because of some accidents or because of some injury, anybody loses their ligaments or tendons and they cut some part of this iliotibial tract and they graft that area. The ligaments are grafted from the iliotibial tract. That is why this iliotibial tract is also very important question in our examination point. Most of us are sometimes they may ask in the viva also. Okay, that is the another important thing. And next, neck of the fibula. Another clinical question related to neck of the fibula. What is this neck of the fibula? And it is related to two important structures. One is laterally, there is one important nerve, that is the common peroneal nerve. And medially, it is also related with the one important artery, that is anterior tibial artery. So, if there is a neck of the fibula because of any damage or any injury to the neck or fracture of the neck of the fibula, it may cause damage to the common peroneal nerve or it may cause damage to the anterior tibial artery. Okay, that is why the neck of the fibula is also very commonly asked question, and or sometimes they may ask in the viva also. Okay, that is what is the importance of clinical importance of the neck of the fibula, right? That is another thing. And related to this epiphysis, you know, that is different types of epiphysis. That is also important. I forgot actually in the general anatomy. That is epiphysis. That is the traction epiphysis, pressure epiphysis, atavistic epiphysis, aberrant epiphysis. These are all the different types of epiphysis. Especially in the fibula. Okay, you see, this is the upper one is the traction epiphysis, lower one is the pressure epiphysis. And here, you know, in the general anatomy, there is a loss of ossification, and especially this bone, especially the fibula bone, it is violating the law of ossification. What is the natural law here? Whichever the ossification center, it appears first and it fuses last. Okay, next the ossification center which appears last, it fuses first. Okay, that is the normal law. But here in the fibula, it is violating. Even though the lower end appears first, it fuses first. Okay, that is because it is a pressure epiphysis. But upper end is traction epiphysis. And there is, what is the explanation? Another rule is there. If there are two different epiphyses, especially one is a traction epiphysis, another one is pressure epiphysis. The pressure epiphysis fuses with the shaft first, then followed by traction epiphysis. Okay, in that way, this fibula is also violating the law of ossification, and this is the explanation related to the fibula. That is why the fibula violates law of ossification. Okay, that is one important point you must keep in mind. Okay, that is another important clinical point related to the neck of the fibula, and another point is related to ossification of the bone, fibula bone, and violation of the loss of ossification. Okay, that is another important point you remember about this fibula. And next, coming to the femur. Okay, this femur is also clinical questions are most commonly asked. This femur, you know, this is the head of the femur, this is the neck of the femur, okay, and here you will get head of the femur, it is and here if you see, this is the anterior part of the neck of the femur, it is covered by total capsule, but posterior part only, half of the posterior part is covered by capsule. So this part is called intracapsular part of the femur. Next, here what happens nowadays, many people they are developing necrosis, femur head necrosis, because of lack there is obstruction to the blood flow to the femur head, especially intracapsular part. We hear this femur head and neck, it receives its blood supply by from the two sources. One is obturator artery, and next is the medial circumflex femoral artery. Okay, medial circumflex femoral artery and obturator artery. These are the two arteries. They are supplying blood to the neck and the head of the femur. Suppose if there is any obstruction to these small branches, and it also receives some branch from the, that is, you know, here there is one fovea. This is called fovea capitis, and this fovea capitis, it provides attachment to a ligament that is called ligamentum teres femoris, or ligamentum teres or ligament of the head of the femur. Okay, here through this only there are some blood vessels, small blood vessels they may pass, but whenever there is obstruction to these major blood vessels, it may produce, especially during fracture of the neck of the femur or due to obstruction to this blood flow, it may lead to necrosis of the head of the femur. In that occasion, the patient needs that is artificial prosthesis implant fixation. That is very important. Okay, that is another clinical point related to this one. And next, here you see, this is the greater trochanter. Okay, this greater trochanter, it is providing attachment to muscles. That is piriformis, especially the piriformis. It is also another important muscle. All of you must practice the piriformis diagram, because this is the called key muscle of the gluteal region. Why it is called key muscle of the gluteal region? Because it is above the piriformis muscle. There are some structures, especially the superior gluteal nerve and vessels passes, and below the piriformis and inferior gluteal nerve and vessels, along with that the sciatic nerve also passes. So that is why the piriformis muscle, whenever you are performing any surgeries, especially related to the hip joint or any surgery in the hip gluteal region, first you have to identify the piriformis muscle, then you have to identify the vessels and nerves which are related to the upper border of the piriformis and lower border of the piriformis, then they proceed to the surgery. Okay, that is why the piriformis muscle, it is a key muscle in the gluteal region, right? So these are all the different clinical aspects related to these bones. So there is a bones of the, and next another thing, you see the tibia. Okay, in the tibia there is another important question frequently asked. That is, you know, this is the tibial, these two are called tibial condyles. Okay, these are the medial, there is a, see, this is the lateral and this is the medial condyle of the tibia. In between these two condyles there is a space. Okay, this is elevated space. This is called intercondylar area of the tibia. Okay, it is providing attachment to intra-articular structures. Okay, that is also very important question in your examination point of view related to the knee joint. That is, what are the intra-articular structures in the knee joint? They may ask. Okay, here what is there? Here there are some fibrocartilaginous structure. This side there is one half moon shape or semilunar shape. This side also one. And they are called menisci. They are called menisci. This is the lateral meniscus. Here is a medial meniscus. Okay, and this half moon shape meniscus is like this. Okay, it is like this shape. Okay, it is having the anterior and the posterior end. Okay, this anterior end is here, posterior end is here, and this also having anterior end, posterior end, anterior end. And there are other two ligaments. So that is one cruciate ligaments. They are called like the cross-like ligaments here. They are called anterior and posterior cruciate ligaments. They are also attached to this intercondylar area. Okay, so what are the structures attached here? First, anterior end of the cruciate ligament, then anterior end of the medial meniscus, then cruciate ligament, then anterior end of the posterior cruciate meniscus. Okay, next followed by there is a posterior end of the lateral meniscus, then that is a medial and posterior cruciate ligament, then followed by posterior end of the medial meniscus. Okay, these are okay. Again, I'll tell you. I repeat. First, there are six structures. First one is the first anterior most is the anterior limb of the medial meniscus. Okay. Next, followed by anterior cruciate ligament. Then, anterior limb of the lateral meniscus. Then, posterior limb of the lateral meniscus. Then, there is the posterior cruciate ligament. Then, posterior most structure is the posterior limb of the medial meniscus. Okay, so, these are all the six structures that are attached in this intercondylar area. And these structures, they receive its blood supply and nerve supply through the middle genicular branches. Already we told in the popliteal fossa, this middle genicular artery is a branch from the popliteal artery, and middle genicular nerve, it is a branch from the, that is the obturator nerve. Okay, these nerves, they enter into the joint cavity, then they supply to the intra-articular structures. Okay, that is why this is also very important clinically, because these are the common structures they tear or they rupture. These menisci may rupture and these ligaments may tear during accidents or injury to the knee joint. That is why these are also playing most important role in movements and they are highly painful. They restrict the movements of the knee joint and they must be corrected or they must be removed by the procedure called arthroscopy. Arthroscopy, they make a hole in the capsule of the knee joint, then they pass a small instrument into the joint. That procedure is called arthroscopy. So that is another important point all of you must know. That is the intra-articular structures or of the knee joint between the two condyles. That is intercondylar area of the tibia. Okay, that is another important point you must keep in mind. Okay. And next, another important thing, that is ligaments, the tendons. That is a tendo-Achilles. You know, that is a calf muscles, especially brachia. There is a what you call a gastrocnemius muscle and soleus muscle and tendon of the plantaris. Together, they form a big tendon in the back of the heel. That is called tendo-Achilles or tendo-calcaneus. That is also very important question in your examination. You have to prepare for that one. Next, there is another tendon. There is a there is a ligament, not tendon. Actually, this is the ligament, ligamentum patellae. Okay, patella bone, you know, it is a sesamoid bone, and here it develops in the tendon of the quadriceps femoris, and connecting to this patella and the anterior tibial tuberosity. In between these, there is a one ligament that is called ligamentum patellae. And this is also very important clinically because this is the most commonly used ligament to test the deep tendon reflexes. Especially in paralyzed patients who are suffering with paralysis. In those patients, you're supposed to, their neurophysician, they're supposed to test whether the sensations or reflexes are intact or any loss. Okay, to test this one, they scratch over the skin, they scratch over the sole, they scratch over the medial side of the thigh. Okay, these are all called superficial reflexes. But deep tendon reflexes, they tap over these tendons, especially the ligamentum patella. And here, if they want to test the biceps, they test here, they tap here. Depending upon the area they want to test, they tap with an instrument that is called knee hammer. Okay, to test the deep tendon reflexes. Okay, this is the ligamentum patella. It is attaching to this tibial tuberosity here. Okay, and from the tibia, the patella to the tibia, here there is a band-like structure. Okay, like this. Okay, that is called ligamentum patella. Okay, that is also important in your examination point of view. Okay, all of you study this one also, right? Okay, these are all the important topics already we covered. If you have any doubt, you can message me. And next, what is there? And deformities of the foot. That is the deformities of the foot is also important. Okay, deformities of the foot. That is a talipus equus, talipus. Okay, planus versus tinnitus. Okay. tinnitus. Okay, if you have any doubt, you just message me, please. I will clarify your doubts. Okay, I think I gave adequate information related to lower limb and general anatomy. Okay, if you have any doubts, you can ask me. You can message me, please. It is open to discuss, right? Tinnitus. Tinnitus actually it is related to the it is a sound in the ears. Okay, that is due to some problem with the eardrum, or it is maybe due to some problem with the nerve. It is a nerve, so that is a vestibulocochlear nerve. It may produce that clinical condition. Okay, that is the tinnitus, right? Anybody having doubt? You may also have MCQs. That is answering MCQs also very important. If you want to answer MCQs, you must study all the subject. Otherwise, it is very difficult to answer. Okay, that also decides your marks. And I think you have an idea about there is a 50% is pass in MBBS, both together. That is practicals and theory. Together you must get 50% minimum pass marks, and in theory you must get 40% minimum 40%. If you get less than 40% in theory, and you may get 80% in practicals, that is considered as a fail. So that is why you must get minimum marks in the theory. Okay, that is the one important thing. Next, anybody? I hope you understand subject. I tried because actually this is my first live program on my channel. Retinacula. Yes, there are retinacula are there around the knee joint. Retinaculum. They retain the tendons of the muscles in their position. Okay, that is why they are called retinacula. Okay, these retinacula are nothing but the defacial modifications. That is in the extensor compartment or anterior compartment, there are two retinacula. That is superior and inferior retinacula. Okay, they retain the tendons of the extensor muscles of the anterior compartment muscles. That is retinacula. Okay, these retinacula also important. They are having that is you practice diagrams related to retinacula. That is they are attached to the two sides. That is one side they are attached to the tibia, another side it is attached superior retinacula it attached to the fibula, and inferior retinacula it is only one side is attached to the bone. The other side it is forming a loop around the extensor tendons. Then again it goes down. Then it attached to the bone. Okay, so these retinacula also sometimes they may ask in the examination. That is, they are nothing but the modifications of dysphagia. That is, if they are present in the extensor compartment, that is called extensor retinacula. And there are other reticula, that is a flexor retinaculum. That is between the calcaneus and the medial malleolus. Okay, it retains the tendons of the flexor muscles. So that is the posterior compartment muscles. They are going through deep to the flexor retinaculum, then they are reaching the sole, then they are attached to the sole of the foot bones, especially that is metatarsals, phalanges, right? That is a flexor retinacula. And there are other retinacula, there are peroneal retinacula, that is a superior and inferior peroneal retinacula. They are confined to only peroneus longus and peroneus brevis. These retinacula, they keep the tendons of the peroneal muscles. That is a peroneus longus muscle and peroneus brevis muscles. They are present in the lateral compartment of the leg. Okay, one thing you must remember, that is the peroneus longus and peroneus brevis only the lateral compartment muscles or peroneal compartment. It is also called or fibular. Some books they given as a fibular compartment. Fibular compartment or lateral compartment or peroneal compartment, all are same. The muscles of the lateral compartment or peroneal compartment or fibral compartment is peroneus longus and brevis. Only two muscles. And nerve of the peroneal compartment is the superficial peroneal nerve or musculocutaneous nerve of the leg. Okay. So these are the retinacula. They keep the tendons in its position. Okay. That is also sometimes they may ask. Right. Next, any doubt? Yeah, back of the thigh. Sorry, I forgot. Back in the back of the thigh, there is one important question for your exam. That is hamstring muscles. Hamstring muscles. Hamstring muscles. There is a criteria for hamstring. That is true hamstring muscles and false hamstring muscles. That is hamstring muscles are 4. That is semitendinosus, semimembranosus, long head of the biceps femoris, and there is a adductor magnus. Hamstring part of the adductor magnus. Okay, if you want to call any muscle as a hamstring muscle, there is a criteria. That is, first it must take origin from the ischial tuberosity, then it must get inserted to the tibial condyle, and then one of the leg bones. Okay, and it must be separated by the tibial component of the sciatic nerve. Sciatic nerve. Okay, these are all the, and it must produce flexion at the hip, extension at the knee. Okay, that is the, sorry, flexion at the knee and extension at the hip. Okay, that is the criteria for the hamstrings. Whichever the muscles which are following this criteria, they are called true hamstrings. The muscles which are not following this criteria, they are called false hamstring muscles. Especially that semitendinosus, semimembranosus, and long head of the biceps and adductor magnus. Okay, and short head of the biceps, it is not at all following this rule. That is because it is taking origin from the linea aspera and it gets inserted to the lateral condyle of the tibia, but its origin is from the linea aspera. So that is why it is not following. Then if you take the adductor magnus muscle, that is taking origin from the ischial tuberosity, but it gets inserted to the adductor tubercle of the femur. That is in the, or the medial condyle of the femur. There is one bony prominence that is called adductor tubercle. So it is not attaching to the leg bones. Okay, that is why these two are the false hamstrings, and semitendinosus and semimembranosus are the true hamstring muscles. Okay, that is the thing. And another muscle in the medial compartment, gracilis muscle, is also important. Sometimes they may ask gracilis muscle. Okay, you also study about this gracilis muscle. Okay, the muscles, concerned muscles. The muscles piriformis, adductor brevis, gracilis, and soleus muscle. These muscles are important in the lower limb. And sesamoid bone, already you know, that is a bones classification. Sesamoid bone, sometimes they may ask as a short answer. What is the specialty of the sesamoid bone? The best example and the largest sesamoid bone in your body is the patella. It is not having any marrow cavity and it is not covered by periosteum. That is why if there is a fracture of the patella, there is no union of the bone. You have to fix with the wiring. Okay, that is another important clinical point you remember. Okay, right? I hope you understood my class. It is helpful for you. And if you want any further classes, free to ask me. I am ready to share my knowledge. Okay, thank you. Is there any person needs a doubt, clarification? And another important thing, thank you very much for patience listening my class. Okay, thank you. Bye. Bye. Good night to all. Thank you very much.